Like so, but I believe it's not showing like that on your screen.
It will come probably.
It's still not on full screen.
Not yet.
Sir, I will help you, sir. Sir, stop your screen. Right, sir. Select full screen or entire screen and then share.
Yeah, that option, unfortunately, that button is inactive.
You have to select it, sir, and then share.
Yeah, I know. I select it and that button is, the share button is not active when I opt for the entire screen sharing.
Shweta, you are giving permission for this?
Yes, sir.
Yes, I just checked it before.
Yeah.
Sir, open your PPT in slideshow more and then select it, sir. Make it your PPT in slideshow and then select it, sir.
Sorry for this, but unable to do it.
So just share your slides. We are able to see even in that smaller format. So
I know, but
Sir, I will give you a suggestion. If the slide is same, so can I share it from my end?
yes.
Slides are not the same. What I'll do is, can you ask Dr. Nagesh to do it, and I'll mail this presentation to you, and you can run it from your end.
Done, work. So maybe over to Dr. Nagesh.
Yeah, I'll just mail my presentation to you. Should I send it to? I'll send it to Huda.
Huda.
All right.
Okay, we can meet with Dr. Nagesh. Great.
Is my screen visible?
Yes, it is visible.
It's in the slideshow.
Yes, Dr. Slideshow. Yeah.
So, good evening, everyone. So, I'm supposed to be talking today on off-label indications of apremilast. So, to begin with, I'll just give a brief introduction of the molecule. We all know apremilast is a PDE4, phosphodiesterase E4 inhibitor. It is more of an immunomodulator than immunosuppressants. So that's why we are talking about it today over here. So it has been extensively studied in plaque psoriasis and psoriatic arthritis. It has been approved basically for the treatment of psoriatic arthritis, psoriasis, and also for the oral assessment patients. It has been a good value addition in the treatment armamentarium in dermatology. So it has a balance between both safety and efficacy. So how does this act? So basically it is a PDE4 inhibitor. Because of the inhibition of the PDE, there is accumulation of cyclic AMP, and this will trigger the other pathways. So there will be increase in the anti-inflammatory mediated anti-inflammatory interleukin like interleukin 10, whereas the pro-inflammatory pathways will reduce. Like so, here in this slide we can see that apremilast binds to the enzyme phosphodiesterase 4, increase the level of cyclic AMP. There is increased level of the anti-inflammatory cytokines like interleukin 10. Also, there is a reduction in the levels of the pro-inflammatory cytokines like TNF alpha, interleukin 23, interleukin 12, leukotriene B4. So, whenever we talk about the immunosuppression or immunomodulation, it can happen at three levels. It can happen at the receptor level, or within the cells it can happen, or it can specifically target the interleukins. Like you specifically target the interleukins in case of biologics. General immunosuppression happens in drugs like methotrexate or cyclosporine. So here it is acting within the cells or once again on the inflammatory mediators like the interleukins. So it is creating the more towards more generation of the anti-inflammatory cytokines and suppression of the pro-inflammatory cytokines. That's how it acts in this. So one more picture where we can see that how it blocks and how the different anti-inflammatory cytokines like TNF alpha, interferon gamma, interleukin 12, 17, 22, and 23 are reduced, whereas interleukin 6 and 10, which are the anti-inflammatory cytokines, are increased within the cells. So coming to what are indications for apremilast? So the FDA approved indicates include the patients with moderate to severe plaque psoriasis, for phototherapy and systemic therapy, and patients with active psoriatic arthritis, also the patients with oral arthritis. So whenever any new drug comes, other than the FDA approved indications, we also think where else we can use, because there are various indications where it can be used other than the approved indications. So here it has been tried conditions like alopecia areata, lichen planus, atopic dermatitis. Based on the pathogens of disease, we have tried to use in various conditions, DLE, ankylosing spondylitis, rosacea, and few more indications where it has been tried in small number of cases. Why are we thinking of off-label indications? So we know PDA4 is widely expressed in macrophages, lymphocytes, natural killer cells, as well as the non-hematopoietic cells like the cancerocytes and the synovial fibroblasts. Also in the peripheral mononuclear cells, PDE4 inhibition is shown to decrease the production of pro-inflammatory cytokines like the human TNF alpha, interleukin 12 and 23, interleukin 12 and 2, while upregulating the anti-inflammatory cytokine. Considering this broad range of cell types which are affected by these immunomodulatory effects of aprilash, this has been promoted in its off-label uses, like in basically dermatology. So what are the indications? So alopecia areata. There are a lot of studies of use of aprilash in alopecia areata, but however, the response has been not that great. There has not been a significant improvement in SART score, not much benefit. So I have not used in many cases, but however, it has not shown a good response. Basically, the use of aprilash became more during this COVID season. So post-COVID area where we are a little bit hesitant to use the immunosuppressant like methotrexate. In such places, we use a lot of this aprilash. So however, alopecia areata and all, we have not seen a significant response. There are studies available. A lot of RCTs are available with alopecia areata. Coming to atopic dermatitis. So many RCTs and open label studies have been done. This has been shown a good improvement compared to placebo. As I told you, it was a good drug to be we usually use during the post-COVID era where we are hesitant to use immunosuppressants, and it has shown a significant response also, which can be used as a steroid-sparing drug still. Behçet's disease, yes, as I told you, for the oral ulcers, the pain has been FDA approved also. So it responds well to aprilash, particularly the oral erosions where the painful lesions are there. So it has shown a very good response in case of Behçet's disease. So definitely it can be used in place of colchicine and other drugs. Aprilash can be a good alternative to the other drugs. Lichen planus. Lichen planus definitely responds well to aprilash. Whenever like this lot of many times the recurrence of lichen planus keeps happening, and we used to we need to use immunosuppressant. Most of the times we use cyclosporine, or a long-term steroid can be avoided. Instead of that, we can use aprilash, and it has definitely shown good response. There have been case reports where lichen planopilaris has responded very well. Even patients of lichen planus pigmentosa have responded. Reports of that responded well to aprilash. There is one more indication where it can be routinely used. So I usually use this now for the palmoplantar psoriasis of the hand eczemas. Responds very well to aprilash. So it can be used alternative steroids and other immunosuppressants. They really respond well to aprilash. And there are less common indications. If you go through the literature, if you search for the evidence for all the previous indications I have mentioned, there have been RCTs, there have been open label studies, at least good evidence is there. However, there are few places where it has been tried, like hidradenitis suppurativa. There are few cases which have been studied and it has been a good response, but I cannot tell that okay, you can use aprilash every time. But however, it has been tried and it has shown good response. DLE, cutaneous sarcoidosis, rosacea, scalp psoriasis. Scalp psoriasis definitely yes, it can be tried, so it helps. Palmoplantar pustulosis also it helps. Vitiligo and pyoderma gangrenosum, maybe if the regular things are not working, you want to try a different thing, yes, then maybe we can try this one, but it is not a very strong recommendation. So however, when we are using this drug, so why are we using this drug instead of the things? One is like the regular routine monitoring like a methotrexate or a cyclosporine, any of the drugs might not be needed. So we, that is one reason why we have to we can use this drug. It is more of an immunomodulator rather than an immunosuppressant. So hence, and also the monitoring like a liver function test or the renal function test is not routinely recommended. So it can be used. However, there might be a need for little reducing the dose in case of renal function. What are the common side effects what we come across? There might be a list of side effects. However, in practice, so consider the practice-oriented thing. What is that do we in practice? We need to see. Headache is the most common side effect. Nausea, diarrhea, depression has been mentioned, but as a part of the clinical trials, but however, totally not seen. So, why are these side effects and how do we avoid this? So, initially when apremilast was started, was brought into the market, it usually came with a starter pack. Like we used to give 10 mg on the first day, 10 mg BD on the second day, 10 mg, 20 mg in the third day, then 20 mg BD, then 20 mg, 30 mg, and 30 mg BD. Within a week, you used to reach a dose of 30 mg BD. The proposed dose of apremilast is 30 mg twice daily. So when we are upgrading the titrating the dose faster, the chances of that what usually has been noticed is the chances of side effects are less. Sorry, more. Sorry. So however, to reduce this side effect, what we can do is we can start with a lower dose for around 5 days or a week's time, then gradually increase gradually titrate the dosing of the drug can be done. So this can be prevented. So diarrhea usually is a type of secretory diarrhea because of the chloride channels as well. So that usually settles down by the symptomatic treatment and supportive treatment. Even headache it can reduce with gradually with time. Just the counseling will help. So these are the things which we can in practice try to do to prevent the side effects of this drug and use it routinely. And as I told you, this can be a good drug in conditions like lichen planus, palmoplantar psoriasis, scalp psoriasis, hand and foot eczema, the palm lesions. Even in atopic dermatitis has been tried. However, because of the coming of the other newer drugs, now it has taken a step back. But still, I feel it has got a role to play in our regular day-to-day practice, and it can help the patients when used judiciously, and we can whatever the side effects has been mentioned, which can we can try to manage with the dosing because the various doses are available, like 10 mg is available. Some patients use it in practice. Thank you.
Thank you, Dr. Nagesh, for that talk on various indications of apremilast, off-label indications of apremilast. It was really helpful. I think probably during panel discussion we'll discuss more about these things. But are we ready with Dr. Avir's presentation? Okay, great.
Thank you very much.
Please go ahead, Dr. Avir.
Thank you very much. Apologies for the glitch earlier. So, the long-term management of psoriasis is or can be as tricky as the initial clearance, and this is something that bears a little bit of reflection and a little bit of thought. And if we get good at this, and then it's a significant skill to have, and our patients will appreciate it. So this involves both topical and systemic therapies in terms of managing psoriasis, because typically when you talk about long-term management, you assume that your initial treatment has worked and then you are trying to manage it, which might involve a lot of topical therapy on residual plaques or like a maintenance therapy. So next slide, please. It's extremely common. We all know it. India has almost 35 million of these 125 million people. So we have a huge number. Next slide, please. These are some of the classifications. There are the phenotypic classifications which talk about what it looks like, where it is located, inverse, palmoplantar, nail, what is the etiology, drug-associated, Koebner-Eyes, etc. It has a lot of symptoms which sometimes we underestimate. It causes pain, stinging, burning, itching, in addition to the psychological morbidity and the kind of discrimination that our patients may face. And of course, by onset also, there is some merit in this kind of classification where whether it started before 40 or after 40. Some studies have shown that it does behave a little bit more severely if it starts before 40. Next slide, please. And this is another thing that has an important implication on the long-term management of the disease, comorbidities. And sometimes we only consider comorbidities in the terms of how bad the disease will be, how aggressively we'll treat it. But in terms of what we are treating it with, it bears thinking about that there are these diseases that are associated with psoriasis, which can affect the absorption, distribution, and elimination of drug flows. If a patient takes alcohol, doesn't want to stop, there's a lot of problem in potentially hepatotoxic drugs. Obesity, as we know, worsens the response to all forms of systemic therapy, and also affects drug distribution, metabolism of drugs. Diabetes can impair kidney function, affecting your ability to use drugs like cyclosporin or tacrolimus. And of course, diseases like Crohn's disease and other GI problems can also affect which drugs you can use and whether they are effective or not. So it's important to remember these comorbidities in long-term management as well. Next slide, please. So now we'll talk about the long-term management in terms of topical therapy and what are the factors associated with that. Next slide, please. So the chronic nature of the disease, and we know that there is no cure. So almost inevitably, in probably more than 80 to 90% of patients, we will need some form of therapy to maintain the remission. And that is where it goes beyond just therapeutics. Goes to patient interaction, your rapport with the patient, how much the patient understands the disease, how much we understand what the patient wants, and things like that. Next slide, please. And the problem, if you look at guidelines, is that guidelines don't usually talk about this aspect. Whether to give one single topical agent to maintain, or hotspots, or lesions that have not cured. Might it be a DCI or a steroid or a retinoid or vitamin D analog? Whether to give combinations, etc. Not very clearly mentioned in guidelines, but there are some guidelines which we'll see in the subsequent slide, which do give you a hint of how to manage. Next slide, please. So the previous approach was to, this is specifically about topical therapy right now. So step one was to give a potent corticosteroid, depending on the location, of course, it might be a moderately potent also, and a vitamin D analog both. And then once it is cleared, then you transition. You should replace it with TCI or corticosteroid on the weekends and vitamin D analog every day. And then step three was a plain, long-acting, safe drug like vitamin D analog or TAR or dithranol or tazarotene for maintenance. So this was the earlier approach, which is valid in many cases if they have a tendency to relapse very quickly and the disease is relatively localized. Next slide, please. But there's another approach which talks about intermittent maintenance therapy, which might be a bit safer and more effective. So this kind of three-step approach compared to this approach where you initially clear it with an aggressive therapy which contains possibly calcipotriol associated with betamethasone dipropionate or even clobetasol. And then there are multiple studies done on this where you apply this combination of calcipotriol and betamethasone dipropionate only twice a week. Might be 2 consecutive days or with 2-3 day gaps in between. And this has been shown as a very effective strategy in managing difficult psoriasis, which is not severe enough to merit systemic treatment, but still needs topical therapy to remain clear. And this evidence extends to the foam formulation on the scalp. Next slide, please. To the classical plaque psoriasis with the ointment formulation, as well as the flexures also, where tacalcitol, etc., with milder steroids have also been used. And there's evidence for intermittent therapy for that as well. And these are the various consensus guidelines that do talk about this kind of approach. So both the Asian, French, German, and the UK guidelines do favor this kind of intermittent therapy, which should seriously be considered by all physicians who are treating psoriasis. Next slide. And the evidence is not very great as compared to systemic therapies, but you can see that there is significant evidence in the top 2, calcipotriol, either monotherapy or combination therapy in thousands of patients. Evidence quality is varying from A to C, but there is a same evidence for other vitamin D analogs as well, and including topical steroids, both betamethasone valerate and dipropionate or clobetasol. So we should not be worried about, and more so with patients being worried about steroids. This should give us confidence, and this confidence should be transferred to our patients that in this way of long-term management that I just talked about in the previous few slides, it is a safe and effective way of managing the disease. Next slide, please. And so now comes the tricky part. We all know the medicines, but how to get the patients to use them, not stop using them, how to make it pleasant for them to use. So the treatment goals should be understood both from the point of view of the physician as well as the patient. So our concerns are efficacy, quality of life, safety, but the patient's perspective might be cosmetic elegance, less disruption in their lifestyle, and they may have particular areas which they want very clear, and they might not be bothered about other areas. They might not like the smell or the feel of a particular drug. So these are all things that we need to talk with the patients and come up with a sort of a consensus prescription where both all the concerns are and theirs are handled. And also the adherence depends entirely on how well the patient likes or finds the treatment convenience. So the frequency of application should preferably be once a day. The formulation should be pleasant to use, preferably a gel, foam, or a liquid. It should not be too complicated. Corticosteroid phobia should be specifically addressed by talking about it and reassuring the patient. And so all these things should be taken into account. Next slide, please. And of course, this results in good adherence, and this is the main challenge. So there are several studies that show how abysmal the adherence is. So you can see that in almost all diseases like acne, eczema, etc., adherence to topical therapies ranges from about 50 to 70%. In psoriasis, the average across trials is about 40%, even for effective treatments like topical steroids. And the reasons are many. Steroid phobia is just one of them. The other reasons might be just a human tendency to become a little complacent when the disease starts responding, or simple forgetting, or so that there are so many other reasons which require constant contact with the patient. Next slide, please. So this was a very interesting study that was published a few years ago, which tried to find out what to do to improve this kind of 30 to 40% was established where a nurse talked to the patient, and there was a clear-cut, multi-point agenda given to the doctors to talk to the patient, which added about 10 minutes to the consultation, and phone calls were done, reminder apps were given to find out what works to get the adherence rate up. Next slide, please. And so the results were that all patients benefited from this proactive management where the doctor talked to them, the nurse talked to them, and they were given various reminders. And patients with more severe disease showed a greater benefit than the milder patients. Next slide, please. But you can see that even with all this, regimented approach to trying to, only about a 5 to 6% increase was possible in the responder rates actually. So even with good adherence, the responder rates were not that great, but they were statistically significantly better. So from about 31% to 36%, they went up. Next slide, please. And what aspect of this program was the most effective? The patients rated the one-to-one conversation with the dermatologist as the most effective. So unfortunately, there is no easy and shortcut way of writing a prescription for the next 6 months and hoping that the patient follows up. So one-on-one conversation is the most powerful way of adhering, getting the patient to adhere, followed by one-on-one conversation with a trained nurse, and then of course patient information material, telephone reminders, etc. rank much lower. So improved communication, regular follow-up every 6 to 8 weeks seems to be the only way to do this. Next slide, please. So now we come to moderate to severe psoriasis, and here we talk about how to maintain a disease that requires systemic therapy. So here the key considerations are how fast our therapy works, what are the adverse events, and what is acceptable with regards to the comorbidities of the patients and their specific tolerance. What is the long-term safety profile of the drug that you're using? And of course, like topical therapy, what does the patient want? Do they want a tablet? Do they want an injection? Do they like intermittent treatment? Do they want something regularly? What is their lifestyle? Next slide, please. So again, more of the same things are required for systemic therapies. You need a strong relationship where the patient trusts you, believes you, you are open for them to come back with questions, you are educating the patients, and follow-up visits or calls are regular, they are scheduled, and the patient participates. So you always talk about, we are going to do this, what would you like to do? Do you like this particular drug or not? What was your experience? These kind of open-ended questions make the patient believe that they have a stake in their own treatment. Next slide, please. So this was one approach. We did this study when I was in PGI more than 20 years ago. So we had mostly methotrexate, and all the other drugs, systemic drugs, were either too expensive or they were not widely available. So we tried this approach where we gave methotrexate in that particular time of the year when the psoriasis was the worst, and then we tapered in the next 2-3 months and tried to manage with coal tar, heliotherapy, etc. And then again, when we knew that the season was coming, we gave it, and we showed that it was an effective way of controlling it over many years. So this was a very long-term study of almost 10-15 years, where we could see that this was possible. But it requires a lot of intervention, a lot of monitoring, and it's not really satisfactory. And now we have many more drugs. So the other way of doing it, instead of this multiple short-term therapies with potentially toxic therapies, next slide please. So we have a lot of therapies with different sets of adverse effects and different kinds of tolerances and different pros and cons and strengths and weaknesses of drugs. So we devise a sequence in which we want to maintain the patient long term without causing toxicity. So this was initially designed for patients who wanted to avoid long-term methotrexate. So this was a use of therapeutic agents in a deliberate sequence to optimize the therapeutic outcome. So 3 phases. First is a quick fix clearing phase, followed by a transitional phase where we are stepping down on the initial drug and introducing the second drug, and the maintenance phase, typically with a drug that is much more safer, cheaper in the long term. So typically, for example, it was cyclosporin for the first 4 to 8 weeks, followed by an acitretin overlap while you are tapering the cyclosporin for 2 to 4 weeks, and then stop the cyclosporin, continue on acitretin. Now, instead of acitretin, it could be methotrexate or phototherapy or apremilast in today's scenario. So this is sequential therapy. Next slide, please. Then we have rotational therapy to maintain remissions. So once a patient is in remission, but we don't want them to be exposed too long, so that we are worried about long-term organ toxicities, then every 1 to 2 years we rotate. For example, this is one sequence: methotrexate followed by PUVA, followed by cyclosporin, followed by acitretin, and back to methotrexate. This is for patients who have particularly severe unrelenting psoriasis, which requires systemic therapy and is not maintainable by what we talked about in the first half of this presentation, that is topical therapy. So this was again designed in the era when we had the methotrexate cumulative dose, and the recommendations were to do a liver biopsy every 3 to 5 months, and there were maximum doses permissible. But currently we know that with modern monitoring, good patient selection, we do have more flexibility. We don't have to do liver biopsies. We can do fibroscans and other things. So we have more flexibility in rotational therapy also. Next slide, please. Now this slide again shows you how poor really patient adherence even with systemic therapy is. So the orange bars are how many patients refilled one prescription within the first 6 months, and the green bar shows any duration, did they ever actually come back for a refill or not. So with any treatment, you can see that the number of first refill within 6 months was just under 50%, and over a lifetime it was just about 75%. These are not great numbers for a chronic disease, and these numbers are highest for topical corticosteroids. So patients like those, and they do refill them, and they are lowest for things like PUVA, which require multiple office visits, systemic therapies which are toxic or require multiple investigations, and of course see the long lines of no treatment. So a lot of patients stop treating themselves. So again, this is a sobering reminder of what we might write on the prescription, but what the patient actually does is a different thing. Next slide, please. And this is what patients actually do about the laboratory test that we tell them to do. Renal function, the blue is the renal function, orange is the liver function, and green is the CBC. And you can see that the recommendations for methotrexate are followed. Pre-treatment recommendations are followed by about 3/4 of patients, but then the later recommendations, the adherence to the investigations falls down to very quickly to about 40 to 50%. So a lot of patients are taking these drugs without monitoring, or with very little monitoring, almost half of them. With biologics, these numbers are slightly higher. You can see that they are to the tune of about 60% throughout, and this is also because not much monitoring is required anyway. Next slide, please. So this graph again shows very clearly that why biologics are considered the best drugs for long-term maintenance for moderate to severe psoriasis, because they are intermittent, don't have to, mostly if they cause clearance, you don't have to take a pill or to apply an ointment. You don't have to do too many tests also. And so you can see that the adherence to biologics is the highest. That's the top graph in red, followed by drugs like methotrexate, and other systemics are quite low. Next slide, please. So these are the various strategies before I end to improve treatment adherence. Educate the patient, simplify your treatment regimen, don't make it too complicated. Once daily drugs, intermittent drugs. Maximize the placebo effects by talking about the patient's psychology, minimize the nocebo effects by reassuring the patient, minimize treatment costs, early follow-up visits. Don't give too long prescriptions because adherence falls drastically after the first 6 weeks. Have short-term treatment goals. Tell the patient next time we expect this much improvement, reminder programs, etc. All these things help. Next slide, please. And so this was the highest rate of persistence, as you can see in psoriasis, is with these biologics, which cause very fast clearance. And risankizumab needs only once in three months injections. So these are the drugs which cause the least amount of disruption to our patients. But these can only be given in India to very few patients who can afford them. So we have to make do with various other strategies that I was talking about. Next slide, please. Now, apremilast has excellent evidence for long-term use, 30 milligrams twice a day. Very, very large studies like the PALACE trials have been done, and the incidence of adverse effects is very, very low despite long-term exposure. So far, it has not revealed, any alarming side effects apart from some that are few and far between. Very favorable risk-benefit profile is there. Next slide. So in various prospective as well as retrospective studies, the retention rates are pretty impressive. For any topical therapy, 77% for 1 year and 64% for 5 years are excellent numbers. And this is mainly because if somebody doesn't tolerate apremilast, it becomes obvious in the first week or two. But if they do, they tend to stick to it. And so 30 milligrams per day is the dose that the patients like most often. So once they stop visiting us, 66% of them were taking one tablet of 30 milligrams per day, which shows us that this dose is also pretty effective in the long term. And so this study showed that if the patients have a specifically extensive psoriasis, which is not too bad, so PASI under 10, this is a very good drug for that. Next slide, please. So this is where the where the place of apremilast is. We all have to find our particular ways of using it. We'll talk about it in the panel discussion. But it is a very safe drug, either monotherapy or combination. It works especially well in combination with almost any other biologic or non-biologic agent because of its safe nature. And for maintaining remission induced by biologics or other fast-acting drugs, it is an agent of preference. In my hands also. Initial efficacy is about 4 to 6 weeks, but then you should continue it for the long term. Next slide, please. Monitoring, Dr. Nagesh has already talked about. A CBC should be conducted at least once or twice a year, that's all. LFT also should be done once or twice a year. Additional laboratory monitoring all depends on the patient's comorbidities, etc. An initial question about depressive symptoms, etc., might be warranted if a patient has that kind of history, but otherwise nothing more than that. And a slow taper, which Dr. Nagesh talked about in the beginning, is much more helpful in getting many patients onto apremilast rather than the company recommended fast, ramp up in the beginning. Next slide, please. So these are the recommendations that we came up with. There's a group of 10 or 12 experts. We published this paper a couple of years back. And we also recommended that even lower dosages like 20 milligrams BD or 30 milligrams once a day are very good. Even in the PALACE trials, 20 milligram BD was statistically almost similar to 30 milligrams BD, and it is much better tolerated by many patients. Many patients do well with 20, but 30 they can't tolerate. So this is a very good way of getting more patients onto this safe drug. Next slide, please. Next slide. We must remember this aspect always. This is very, very important apart from drugs. So we must talk about these aspects to the patient and make sure that they are well taken care of in this regard as well, in addition to clearance of the skin. Next slide. Same thing. Next slide. And this is my final slide. So long-term management is all about balancing patient expectations and physician objectives, which I talked about right in the beginning. Patients' expectations are cure, friendly, empathetic doctor, improve quality of life, and our objectives should be that we clearly tell the patient what we are trying to do. We talk about their beliefs, misconceptions, concerns, feelings, and expectations, and overall view of the treatment, and we talk to them with honesty and clarity. Then, of course, long-term management should not be very difficult. Next slide, please. Thank you very much.
Thank you, Abir, for that comprehensive actually talk on maintenance of psoriasis with various forms of therapy. I think we're ready to go for panel discussion. During that, we'll revisit some of those issues. I will just share my presentation on the panel discussion. Are you able to see it?
Yes.
Okay. So I'll just preface it by saying that this presentation on the questions regarding panel discussion excludes biologics and psoriasis not requiring systemic treatment, because psoriasis is a quite a big subject, and we could discuss it all night and not still finish it. So we had put some limits somewhere. So for that reason, though Abir has quickly touched upon biologics as well as topical treatment, I will leave it at that and speak about the more commonly concern or aspects of psoriasis maintenance with respect to conventional systemic therapy, because most of our patients with moderate to severe psoriasis, who are the treatment problems mainly for as far as dermatologists are concerned, they are the points of discussion here. That is what I gather from the title regarding maintenance therapy, long-term maintenance therapy of psoriasis. So, this question, all of us who manage psoriasis must have faced, and I feel that this is a very important soft skill that we must develop about how to word the answer to this question, because once psoriasis is clear or almost clear, even if it is not completely clear, and still we have a limit of some drugs, limitations with some drugs not being able to clear 100%. So this question may be asked by the patient when you write the same prescription next time, and to continue with the medicine, as is bound to happen with many patients with psoriasis. So how do you handle this question? How long do I need to continue this treatment? Abir, you want to take it, or
Yes, sir. So, specifically in the context of once it has cleared and now the patient wants to quickly get off, I tell them that we will see. Now that you are clear, now I'll try to minimize your medication. So that's a positive message that I immediately give them. So I'll try to reduce the dose. I'll try to reduce the number of topicals. I'll try to reduce the number of drugs you're on. So that's a positive that they get out of it. And then we'll see. We'll discuss this again at your next follow-up. I try not to give them too long follow-up. They say, now, okay, now I'm fine. Can I do this for 6 months? Can I go away for 6 months? So so I try to say, no, so you dangle a carrot. You say, no, if you see me in 2 months, if you're doing well, I'll reduce this further. I'll probably get you down to just 1 tablet, or 1 tablet a week or something like that. So that's how we take it turn by turn,
So it's important to give them hope for the next visit.
Yes.
Because unless you have a plan for the next visit, they may postpone the visit.
Absolutely. So you tell them
give a message regarding the next visit.
Yes.
Dr. Chandravati, you have any comments on that?
Yeah, yes. When a patient of psoriasis comes to me, First and foremost, I tell them this is a chronic disease like diabetes or hypertension. You have to be maintained by some drug or the other, depending upon the severity of the disease. So, this is what first day itself I tell them, and prepare their mind that this is a chronic disease. There will be flares on and off. Sometimes it will go down. Sometimes it goes up. So, accordingly, we'll have to treat it. So, what I do, suppose if it is a severe case, suppose I will start on a systemic treatment like methotrexate or cyclosporin. But if it is less than 10%, most of the time I do manage with topical treatments.
Okay, Dr. Nagesh, want to
Same actually, like with initially only. So I tell them that initially few months they have to come. Maybe the visits might be a little bit frequent. Maybe once it settles down, so they might need a longer treatment, and they usually call them once in 2 months or this one, and we tell them like how I can reduce the duration of this one. And as ma'am told, something similar to diabetes or hypertension, where at least there you have to treat the treatment throughout your life, you not stop only. Here it's not like that. Maybe in between you can give breaks. Like only exacerbation we can increase the dose, or then maybe we can give a break of the drug also in between. So we need to follow them on and tell them that it is something which is going to take a long time. It depends on like come for the first time, maybe we can tell it might. We don't know when it comes back, when it comes for the first time. But when people who come already taken it for a long time and come, they already know that it is going to be there. So there it's more all the more important. Tell them that okay, it is, you know that it is there and what we have to do for it. More important is if you stop, you know it exacerbates. So better is that we'll maintain with the best possible dose and with the minimal amount of interventions. That's what I usually tell them.
Okay, and how do you counsel patients? Yeah.
One more thing. Once they ask this question, it is an excellent time to talk about comorbidities. And again, dangle another carrot in front of them to see if you lose weight, if you stop your alcohol, if you start exercising, there's a good possibility that we might be able to completely get off after a few months. So it's an excellent time when they are receptive, they want to get off the drugs. You tell them that there are these are the non-pharmacological ways of managing the disease.
I usually tell them, like they're alcoholics and all, like, see, we have two drugs over here. One is a methotrexate. If I have to use a methotrexate, we have got a methotrexate which is a cheaper one. We have got a cyclosporin, this one. So it depends on what you want to take. You can reduce the alcohol. Maybe we can go with methotrexate. But if you want to continue with it, then we have to go with the other thing. So we just try to play with this one. That's it. But some people will not want to. The cost factor comes when they have to take a cyclosporin. So they might reduce the alcohol intake. That also happens.
Okay, so I think we'll go to the next slide. This just shows some residual lesions in some patients, which may not clear with even the full dose of your initial medications. So, is there a different way you counsel these patients, Abir? Like you cannot clear all the lesions. No? Sometimes you can't clear all the lesions. No? Some lesions remain. Like for example, in one patient on the palm, one patient on the elbow, one patient on the lower extremity. Lower extremity being most common.
So if there are not too many, then intralesional steroids is one way to go. I even use ditronol. The occasion that I use ditronol is often in this scenario. Otherwise, never. In no other scenario do I currently use ditronol. And sometimes, again, we have to do the top left patient with the hypopigmentation that is left behind, heliotherapy, sun exposure, things like that, phototherapy, they might help. And then sometimes patients themselves come to the realization, and we have to gradually get them to accept that you see you are 90% okay. These one or two lesions maybe are not on visible side, so there, those psychotherapy.
So combination therapy or topical therapy can be continued.
Combination topical therapy continues. Yeah.
Okay, fine. Now, are there any patients who really get cured? What is your experience?
I don't know about cure, sir, but prolonged remissions do happen. We all have these patients who we treated once, and these patients, in fact, become big headaches for us. For me, they bring tons of other friends who have psoriasis and say that, my psoriasis has not come back for 10 years. Now this doctor will do some magic. So I have a couple of troublesome patients like this who have gone into long-term remission. So it does happen. I don't know whether we can call it a cure.
Right. Actually, probably in the beginning only, as Madam Chandravati mentioned, that this aspect should be made clear that we don't use the word cure in terms of psoriasis. We use the term remission. Remission can be long term. We don't know how long it will last, but sometimes it can last forever. That's what probably happens to some of these.
Yes, sir. Usually, what I tell the patient is, it is not cure; it is only control. We can only control the disease, whether you go to allopathy or to homeopathy or Ayurveda. This is what I tell them, because most of our patients, psoriasis patients, after some time with us, they'll go to homeopathic treatments.
Mhm.
So that is why I tell them, see, till now in the world there is no cure for this. But yes, there is very good medicines are there to control the disease. So as and when, depending upon the severity of the disease, we treat you accordingly. Otherwise, you are free from the disease. We don't ask you to come back to us. Just maintain with a moisturizer, and any 1 or 2 patches are there, just use a steroid cream. So that's what usually I tell them. So just Abir was telling, 1 or 2 patches are there. We tell them to accept them in the covered areas.
Okay.
I also don't use the word, actually you don't use the word cure at all. That is the problem actually what happens. There are other fields who tell, okay, I can cure the disease. So what I usually tell them is, like, whatever lesions you have, all the lesions we can clear it. So not to worry about it. But if the chances that it will come back is always there. I don't know whether it comes back in 6 months, I don't know whether it comes back in 1 year. But what all you have on the skin, we can clear it. That is not a problem. So usually I tell them, because the word cure itself is a big word for them, because people use it easily. We will cure psoriasis and other things use it. So they get carried away by that thing. So I always don't try to use that word. So I tell them about the clearance. So all the lesions you have on the skin, it can be cleared. So we can do it and we can treat it, not a problem. I usually use the word treatable. So,
yeah, clearance is a good word actually, and we should probably caution these patients that seasonal recurrences are common. So, which seasons to take care more with regard to moisturizers and other activities, their lifestyle also that can be mentioned. Yeah. I think we will go to the next. Okay, with methotrexate, I think regarding liver toxicity, Abir mentioned.
I often jokingly tell them that I can cure it.
The voice is not clear. Okay, can you hear me? Hello, can you hear me?
Yes, sir, you are audible.
Yeah, okay. So with methotrexate, I mean, we know about the methotrexate liver toxicity, but apart from liver toxicity, do we need to worry about anything else?
Drug interactions is one more thing we should look for, sir. Especially in the people who have renal problems, and whoever is taking any NSAIDs, painkillers, and sulfur drugs, we should be careful about this methotrexate. Of course, you know that alcohol and all that, smoking, these things, all these things are very important,
Yeah.
along with the methotrexate, because this is most commonly used drug by all of us. So we should be thorough with this methotrexate, and also we should make the patient thorough about the methotrexate molecule.
Diabetes and obesity also are relative contraindications, right? So
Yes.
those also we need to keep it as red flags for methotrexate, because they increase the chance of hepatotoxicity as well as renal toxicity
Yes.
with methotrexate. I think maintaining with cyclosporin probably is not a very good idea. Already we spoke about it in the initial quick fix state. You can use it. How about acetretin being used for maintenance? Any comments regarding that?
From my side, sir, somehow in patients of 50 years and above, if I put them on acetretin, they complain of dryness. That is the main cause. So most of the time, I don't prefer to use acetretin in the age group of 50, 60 years of age.
Okay. Anyone else?
Yeah. The main issue with acetretin is to keep a watch on the lipids and occasional. So once in 6 months liver function tests. These are the most issues. Otherwise, they are excellent long-term maintenance drugs. And sometimes, rarely, and this is also a known side effect, they can cause thyroid problems as well, or worsen thyroid. But this is not very common. But again, it's a class effect of retinoids.
I use acetretin for maintenance long term actually. So I have a patient who is there for a long time and they do well. As Sir told, some people, as ma'am told, they will definitely come to a lot of peeling of the skin on the palms and sometimes. And that's one thing we are worried about. Only one patient, like I had a case of pyogenic granuloma, which we usually, but I had a case which had it. Otherwise, it's not a basic problem, major problem. So
especially on the
maintain and just yeah, great. Yes, sir, exactly this. So we had that thing. As soon as we reduced it, the temperature shrunk also. It happened also. So otherwise, it's not a problem. The impressions are acetretin both of them.
The dryness part is not restricted to the skin. It also dries up the mucosae, and it can cause symptoms with respect to each of the mucosae, including the anus. It can cause. Apart from constipation, it does cause fissure. Some patients do complain of that. So
some patients will complain of arthralgia, sir, joint pains. That also some of the patients were complaining with acetretin.
Yeah. And even sorry,
myalgias, arthralgias, depression, CNS side effects. These are all uncommon, but not so rare.
Yeah, I think we need to be careful about the dosage that we use, because the dose reduction can help some of these side effects. Okay, with NB-UVB and PUA therapy, what are the long-term issues? We know the short-term issues with respect to phototoxicity, and a long-term issue with respect to probably eye toxicity is well known. But are there any long-term issues other than that, as far as our population is concerned?
A lot of patients don't like the tanning. They're willing to accept it for the first 3 months, but then they say, when will I get my complexion back? So I find that difficult. And of course, adherence is the biggest problem with this. Once it's clear, they don't like to disrupt their life by coming to the clinic.
So since you mentioned about the tanning following PUA or NB-UVB, when do they get the color back? After how much time?
Also 6 to 12 months in my experience.
Okay, my estimation is longer actually, but anyway.
Maybe. Yes.
Anyone else has any experience?
So mainly it is the adherence is the more major problem, sir.
Okay.
Yes.
Yes.
Yeah, being an institute, we use a lot of narrowband UVBs. A lot of patients come to us actually. PUA we don't use much, but our narrowband UVB is routinely used. A lot of patients refer to the institute. So not much of this one. So as I told, adhering to the schedule is one important thing. How how comfortable we can make them regarding the timings is one thing we have to see. Other than that, nothing much as such.
Okay, I think hospital practice dermatologists would find it very useful tool. Others may not have the equipment or the adequate time for paying so much attention.
The moment of moments are there. A lot of moments are there where you can't give a cyclosporin, where you can't give methotrexate or something like that. We can directly switch out to narrowband UVB in a hospital setting. That's an advantage actually.
In pregnancy also it is safe, so we can use it even during that. About tofacitinib, I think we didn't mention anything about it. Have you had a chance anytime to use tofacitinib, and do you consider it as a possible drug for maintenance in any form of psoriasis?
psoriatic arthritis, after initial clearance with the combination of methotrexate and tofacitinib, then either monotherapy with tofa or methotrexate, whichever the patient's comorbidities permit better, etc.
So
That's one
patients who
scenario.
have
Otherwise,
psoriatic arthritis, apart from that, pure psoriasis,
not a great drug for pure psoriasis anyway. So if a patient is lucky enough to do well with 5 milligrams BD clear, then maybe once a day, the way we do for alopecia areata, etc. Trying to get to the lowest possible dose every 2 to 3 months might be a way to go, but not a great drug for psoriasis anyway, in my opinion.
I agree with that. Any other comments?
Most of the
Yes,
time,
actually, in fact,
even I also use the patient is having arthritis.
Correct. Yeah, because it's the drug of choice actually right now for arthritis.
Recently, I had a patient who had extensive psoriasis actually, but she had left her all the allopathic medicine, the newer medicines, and because she was only taking Ayurvedic or something. And meanwhile, she developed psoriatic arthritis. She had been to an orthopedist where actually had started to visit them. She had come to me and saying that I just continued with the same thing. But she responded, arthritis. Basically, if it's psoriatic arthritis, then it works better rather than psoriasis.
अभी जा रही हो क्या?
As such.
Okay, that's the message I think.
कौन सी फ्लाइट अभी?
Which drug do you prefer for maintenance of psoriasis with renal impairment? I think we discussed that. But any quick comment on that?
In all of these, I think apremilast would be all the conditions. Number one would be apremilast. Then number two would be in general acetretin. All of these. Low hemoglobin, I think we need to be especially careful about tofa, etc. And also methotrexate. Poorly controlled diabetes.
₹4000 से तो हो जाएगी ना, सब तो ऑनलाइन पेमेंट ही करेंगे, है ना? 2-4 चीजें होगी जो मैं ऑफलाइन करूँगी। होटल में ऑनलाइन करूँगी। बस में? हाँ, बस में तो जाऊँगी, बस में जाऊँगी। बस में ऑफलाइन होता है। ₹10 है क्या तुम्हारे पास? ₹10 की नोट या ₹20 की नोट, ₹50 की नोट? 5 रुपए की नोट है मेरे पास। तुम्हारे पास कोई क्लिप छोड़ के गई थी कल? नहीं यार, क्लिप बड़ी ऐसा कोई क्लिप नहीं मिला। खाना बुलाओ, खाना। आई मम्मा यार मेरी खाना बची।